historically, patients would come in and they would get a laparoscopic hiatal repair and a laparoscopic fundoplication. And over the years, there have been a lot of problems with that procedure. From the patient standpoint, it can induce a lot of trouble swallowing, bloating, gasiness that we call the bloating syndrome. And it runs about 15% of the patients. There really isn't a known reason for it. It may have to do with the amount of dissection we do. It may have to do with the changes in the anatomy that we make, but it occurs, it's well documented, and there isn't any true fix for that. One of the reasons we use TIF is because it doesn't induce any of those side effects. And the second reason is because we found out that it's much safer. It's about 6 times safer for the patient to undergo a hiatal repair TIF than it is to go through a hiatal repair Nissen fundoplication. So for patients, I generally tell them they're going to come in, have surgery. It's going to be about 2 hours. Then they'll go to recovery. They're going to be sore in the throat because we put a device down the throat. They're going to be sore across the chest because we repair the diaphragm. They're also going to have kind of a nerve pain in the shoulder because the nerve to the diaphragm comes from the neck level, and that's where they feel it. That generally will last 2 to 3 days. They'll be in recovery for a few hours. Then generally my patients I send home and I have them follow up in the office the next day, make sure their heart rate is okay, make sure their white count is okay, make sure they're tolerating liquids, make sure they're eating some popsicles or some ice cream for the sore throat. And then I have them come back at 2 weeks. Over that initial 2-week period of time, I like to keep them on a liquid diet, soups and protein drinks. Protein will keep them from feeling fatigued, the soups to maintain both nutrition but also hydration. After 2 weeks, they come to the office, we make sure they're transitioning to pureed food. So anything that's like baby food stage. They can eat baby food if they want. They can put anything they want into a blender and eat it, okay? And then they do that for a week. The next week I have them do soft foods. And I define soft foods as anything you can smash with a fork. So we think about foods that you'd normally eat, like cooked peas or cooked carrots. If you can smash them with a fork, you can eat them. Then I do a week of what I call a modified regular diet. What is that? Well, we think of foods that we eat regularly as things that we can pick up and chew and swallow. But there are certain foods that are very hard for the esophagus to handle, especially when it's undergoing a transition where there was no resistance to swallowing something to a change where there's a lot of resistance because we've built that valve. The normal situation is the esophagus contracts and moves things through the esophagus. So I tell my patients it's sort of like watching National Geographic where the python is eating the rat and you see it contract and move down. That's the normal process, but without any pressure at the end, the esophagus is going to get weak and it becomes a little discoordinated. So the diet is designed kind of like rehab for the esophagus. We want the esophagus to strengthen and develop coordination and contraction. So in that 5th week, when they're trying to eat things that are hard to swallow, it can develop a lot of chest spasm, maybe food won't go down. So we have them avoid beef, chicken, bread, rice, and down here in Texas, tortillas. And then after about a week of eating regular foods, except for those, they can go back to regular foods. And in more than 90% of the patients, they're not going to have any chest pain, they're not going to have any chest spasms, they're not going to have any trouble swallowing the foods. For those that do have trouble, what we call dysphagia, we feel like that's not due to the procedure itself, but it's due to scar tissue that is formed over the years of constant reflux that they've had. So just like any patient that's treated for reflux that has trouble swallowing, you would go and balloon or dilate the esophagus. That's what we use post-op. It's no different than dysphagia that patients have pre-op, where they're developing scar tissue because of constant reflux. You dilate them, they do very well for 2 or 3 years until the reflux causes more scar tissue, and then you dilate them again. Except now, after a hiatal repair and TIF, or just straight TIF, you've controlled the reflux, now you've stopped the fibrosis problem, and a dilation usually will do the trick and improve their swallowing.